Can everyone see the screen? Sorry.
Yes.
Okay. Okay. Um, so like I said, so a stroke is actually the medical terminology for a stroke is a cerebrovascular accident, CVA, aka a stroke. The definition of a stroke in layman's term is basically a quote unquote brain attack. It's a sudden onset of focal neurologic dysfunction corresponding to a distinct vascular territory called a CVA. A stroke is the third leading cause of death in the United States. I won't bore you with some facts. Although Wendy gave you some, stroke kills approximately 140,000 people a year. Risk for stroke, for a first stroke, nearly twice as high in African American people. On average, there's a stroke every 40 seconds. One American dies from a stroke every 4 minutes. More than 795,000 people in the US have a stroke annually. Of those strokes, approximately 610 of them 610,000, excuse me, are first or new strokes. 1 in 4 people who have strokes occur because they had a prior strokes, and people that have strokes, the cost is approximately $34 billion annually for health services. So just some risk factors or the physiology or pathophysiology of strokes is all of those cardiovascular diseases such as hypertension or high blood pressure, diabetes, hyperlipidemia, or high cholesterol, cigarette smoking, if you have like a family positive history of cardiac disease and obesity. So basically, there are 2 types of stroke someone can have. You can have an ischemic stroke or a hemorrhagic stroke. An ischemic stroke occurs in 70% of the strokes. When you think ischemic, think of dying. So like a dying brain is a clot or something which is called like thrombotic or embolic that happen to go off into the brain and causes it to die. A hemorrhagic stroke is basically a bleeding stroke. Hemorrhage means bleeding, and that occurs in about 30% of strokes. The main 2 types of strokes that there is a subarachnoid and intracranial hemorrhages. So basically, there are 1,000 different types of strokes, and I will not bore anybody with the different types of strokes because the brain is such a beautiful thing. It has all different types of arteries, and based on the different types of arteries that the clots are in or wherever the braiding bleed is will cause the symptoms. So basically, these are just basic symptoms if someone was to come in with a stroke, and this will help you think about the different types of strokes it may be. So an embolic stroke, the symptoms are rapid and at maximum on the onset. A thrombotic stroke, symptoms evolve over minutes to hours and is like a stuttering course. So it goes on and goes off, goes on and goes off. A hemorrhagic stroke, someone might come in with altered loss of consciousness, vomiting, headache, sudden onset and progress over the 30 minutes to an hour. And a subarachnoid hemorrhage is a sudden onset. Someone will come in and say they have the worst headache of their life. So basically, strokes in the emergency room where I work at, it is certified by the Joint Commission as a comprehensive stroke center. So we recognize as well one of the highest stroke centers in our community. So when there are emergencies, someone has stroke, they more than likely come to our hospital. And so initially at triage, because strokes, like I said, the symptoms can happen very fast, very rapid. So the initial evaluation does happen at triage. When someone comes in the emergency room via, walk in by their own personal car or ambulance, the history and the physical is the most important aspect of it. That being said, because we want to establish the time of the onset and the course of the symptoms over time, because that's going to help us identify what type of treatment the patient will need. We have to perform a careful physical exam to help us identify the possible causes. Like I said, that's going to include like a fast exam because depending on where the clot is in the brain, it's going to present differently. So then we complete like a complete neurological exam that helps us localize that exact lesion or artery that the stroke is in. So a lot of people know like the stroke acronym or mnemonic FAST, which stands for face, arm, speech, and time. That is a quick way to detect and identify signs and symptoms of a stroke. If someone comes in, their face is, drooping, lips drooping, eyes drooping, one side of the face is numb, arms, you can't keep your arm up, speech as well, and the time. So basically, this was developed in the United Kingdom in 1998 to help medical personnel train ambulance staff and help us to identify a stroke, because initially every stroke counts, every minute counts during a stroke. With that being said, because there's a medication that you give stroke patients called tissue plasma actogen, and that has to be given within a timely time frame, within 4.5 hours of stroke presentations. Another thing that occurs, like when someone comes with a stroke, we do like a quick score called the National Institute of Health Stroke Scale that has like numbers. It just says like all different types of things. I won't bore you like with it because you have to do so many things. So it tells, but the main things that you assess, like level of consciousness, their gaze, their visual, their speech, their motor function, their facial palsy. Based off the score, is going to help determine if the patient is having no stroke, a minor stroke, or a severe stroke. The higher that the score is, the more severe the stroke is. Just because someone has an NIH S score of 0 doesn't mean they're not necessarily having a stroke either. So basically, once we put all together in triage, if we note that someone is having stroke-like symptoms, and you're unsure, you call a cold stroke. In our hospital, a cold stroke is basically used to initiate collaboration early with the neurologist and the hospitalist. Since we work in the emergency room, it helps to facilitate a better throughput, and it helps to reduce emergency room boarding times. So diagnostic studies that you want to do when someone presents with stroke-like studies is urgently you want to do a non-contrasted brain CT or brain MRI. That's going to be the most definitive testing when trying to rule out a stroke, because you have to determine the difference between an ischemic stroke and a hemorrhagic stroke, which you see on a non-contrasted CT, and that's going to help us determine the treatment. Also, there are things that mimic strokes, so you also want to do a blood glucose check, because low blood sugars or hypoglycemia mimic strokes. You want to do oxygen saturations, someone that has low oxygen to the brain, that mimic strokes as well, and also accurate body weight, and that's going to be for the medication. Also, other things that you want to get is the EKG or electrocardiogram of the heart, basic labs that we look for, because we want to look at electrolytes, we want to check kidney function, and we also want to check clotting factors, because the medication that we give people help clot the blood. Just a little bit more about imaging. Like I said, we do those because we have to determine the treatment. Hemorrhagic strokes get treated differently than ischemic strokes. So therefore, you have to make sure that the brain is not bleeding before you can give medications. Just other things that you want to do once you identify the stroke. Some things that you want to do is that you want to do a carotid duplex ultrasound. So we have 2 arteries in our neck called the carotids. You want to make sure to see, that's where a lot of the blockage is happened there. In our neck, that breaks off into the brain, that causes us to have strokes. You also want to do an MR angiogram or a CT angiogram, and that's just a testing where they inject dye directly into the arteries to see where the clot is. Also, another thing you can do, like Dopplers of the heart and of the brain, just to figure out if there's a vasospasm. Although, catheter angiogram is the most sensitive and a specific vascular testing to confirm the different types of stroke that someone may have, because it can look directly at the exact artery that the stroke is in. And so basically for treatment in the timeline of stroke, like I said, it's very important. If someone presents to the emergency room with a stroke, you want to identify that stroke within less than 60 minutes. With that being said, because you only have a 4.5 hour window to provide medications. So for an ischemic stroke, the gold standard is tissue plasmagen activator, TPA, or an endovascular thrombectomy, where they go in and they actually use a machine to remove the clot. In order to get TPA, there are inclusion and exclusion factors. The most inclusion factors that you have to be diagnosed with an ischemic stroke greater than 18, and it has to be within 4.5 hours. Some things that exclude you from getting TPA is if you had a prior stroke within 3 months, if you have a brain bleed, if you had major surgery within 14 days, GI surgery, if you had a heart attack within 3 months, if you had a seizure, if you're pregnant. Some alternative treatments to stroke, because like I said, not all strokes are either going to be, not are not going to qualify for thrombolytics, or not all strokes are hemorrhaging. So when someone have these type of things, you can just easily put them on medical management versus having to do any type of surgery. You can give them aspirin or clopidogrel for the next 21 days. If someone has atrial fibrillation, which is a risk factor of stroke as well, they also be on anticoagulation. Treatment for massive strokes, like I said, the most important number one treatment is going to be TPA. So just the overview of strokes and CVA treatment, except for ischemic stroke. The most important thing that you always want to do is medical management. Like I said, we go back to what those risk factors were for strokes: high blood pressure, high cholesterol, obesity. Those are things that we can manage medically, and with lifestyle changes, dietary changes, medications that help reduce your blood pressure in order to treat stroke. TPA, and procedures such as thrombectomy, actually where they go in and remove the clot, carotid endarterectomy, where they go through your carotids and do it, and actual clot removal. I didn't really talk much about hemorrhagic strokes, but going back to it, that's just a breathing blank. Obviously, if your brain is bleeding, we want to try to decrease that pressure, and we do that by doing a craniotomy or a craniectomy. So life after stroke. So basically the extent of a damage caused from a stroke may be not known for weeks. The most important treatment after someone has a stroke is early rehab, and that most often happens on an inpatient basis. So after a stroke is identified in the emergency room, this person goes to the neurosurge ICU, where they have all of those treatments that we had, and then right after treatment, rehab begins. The most important thing is that they have someone come in, a speech therapist come in, they come do a swallow therapy and PTOT. Recovery takes time, and it just depends on how badly the brain was injured and all your other risk factors. For rehab, getting back to life after stroke, like I said, that's just all going to depend on your rehabilitation process, and that all depends on a group of people that's going to be working with you. Now, sometimes that can take up to 3 months, 2 years. It just all depends. But people, doctors, PAs, nurses, speech therapists, physical therapists, occupational therapists, social workers, every one of those natures have the ability to help rehab someone. Also, people go to different types of facilities just based off of their stroke symptoms to help with that rehabilitation. Acute short-term facilities, long-term rehab facilities. They can stay in the hospital, nursing home or rehab facilities for a while as well. And that'll be the end of my presentation. Any questions?
Thanks. I'm sorry, I was trying to get to the unmute button. Thanks, Jasmine. I know it was a lot of information you presented, so if I missed it, I apologize. But how would you say the stress, just normal stress, play a factor in a stroke?
So basically that is like the number one thing too. We always try to provide support for the family as well, because stress is probably the number one thing. And that'll help deter, that's going to deter like treatment sometimes too, because it's like sometimes you don't know like what to do with these people. Personally, my uncle just had a stroke 2 months ago as well, and just seeing the stress off my mother, going through the family, like stress is the number one determining factor, and it plays a role 100%. When someone else is like having a stroke, is because like, right, their heart is already stressed out in that way by having all the other risk factors, and then when you put life on top of that, and work and jobs on top of that, that's going to increase your chance of stroke 100%.
Great, thank you. I think we have a question in the chat. Let's see. It says, do strokes always start on the left side?
No. So that goes back to, like I said, I didn't want to bore anyone with the different types of strokes, but the way the stroke presents, it all depends on what artery it is. We have many arteries in our brain: the middle cerebral artery, the anterior cerebral artery, basilar arteries. So it depends on what artery it is in. The stroke will present on the opposite side. So if it's in the left MCA, the symptoms are going to be on the right side, and the MCA is the most common artery that strokes are in. So if it's on the left side, the symptoms are going to be on the right side, and if it's on the right side, the symptoms are going to be on the left side. But that's just only one type of stroke. There are other strokes that present, like if it's in the ACA, it's on the left side, symptoms are going to present on the left side in that nature.
Okay, thank you. Anyone else have any questions? I know Teresa's helping monitor in the chat, so I'm toggling Teresa. So if you see anything,
Will do.
okay, thank you. Any questions for Ms. Robinson? No. Okay. Hopefully, Jasmine, you can kind of stick around. Maybe somebody might have a question, if you don't mind. Okay. Oh, go ahead, Teresa. You see something?
And so the next question is, how serious is blood clots when someone has them? Is there a difference between blood clots occurring in regarding to stroke symptoms?
I guess it all just depends on what type of blood clots someone have. You can have blood clots in your legs, you can have blood clots in your lungs. And like I said, the most common cause of strokes is blood clots in the carotids here in the neck. But you having blood clots in your legs, in your lungs, which is also called a pulmonary embolism or a deep vein thrombosis, those can increase your chance of strokes. But that's why when we identify those things in people, we immediately put them on anticoagulations or things that's supposed to help thin the blood so your blood don't clot and you can help break up those clots. So like I say, it just all depends on how bad the stroke is. How bad the clot is, where it is. And like I said, the most common causes of clot are going to be clots in your carotid. The ones in your legs and your heart, your lungs, those get identified quickly. Those are treated on anticoagulations. And people that already identified have that, they'll probably be on anticoagulation for the rest of their life to help prevent stroke, because every time you have any type of cardiovascular thing or clots, that will increase your chance of stroke.
We have another question in the chat. What is the likelihood of reversing paralysis once a person has had a stroke?
Like I said, that just all depends on what type of paralysis they have, what type of stroke they had, how long the symptoms were without treatment. It's very hard to say. But that all depends on their physical therapy, their occupational therapy. Once after they have the stroke and they sit down with their rehabilitation team, and the doctors, and they get reassessed daily and weekly. And it just depends on where the paralysis is. Some people, just will have like a weakness in their arm for the rest of their life, or sometimes their arm might be paralyzed for the rest of their life. It all depends on age as well, lifestyle as well. So all of that is hard to say. It just all depends on, your physical therapist, your occupational therapist, your speech therapist, as well, and the, I guess, like the aggressiveness of the treatment.
I can't type my question, but does stroke have a genetic component to it?
It is hereditary. So like I said, it is family history. So if someone in your family have a stroke, the likelihood of you having a stroke is higher than someone else. If you have a positive family history of high blood pressure, and like I said, that's why African Americans are more than likely to have a stroke, because we already have prone to high blood pressure. So we already have that risk factor automatically. It depends on type of, like I said, family and personal risk factors. And like I said, if you have someone in your family had a stroke, you are more than likely, on a higher risk factor to having a stroke. So that's why, doctors and PAs, they try to do medical intervention early, try to put people like on high blood pressure medication or high cholesterol medication early, even though like someone's like, okay, I'm only 30. Why do I need to be on this blood pressure medication? Oh, well, because your mother had a stroke at 45. We want to try to do some preventative measures here to help prevent that. So.
Thank you. There's another question, and I think you kind of alluded to a part of this. What can people do to prevent a stroke?
So like I said, it'll just all be a lot of lifestyle modifications, honestly, to help. It says some things are hereditary, some things like we are just prone to, but we have to be like more proactive. This is a society where fast food restaurants is easily available. So we need to have like self-discipline. Like, I'm not gonna go get that burger. I'm gonna go home and eat a salad. I'm gonna go home and eat my veggies. I'm going to have control over my diet. Don't drink sodas because sugars, those cause diabetes, right? And diabetes, once you have diabetes, then that just opens the door wide for you to have a lot of microvascular complications such as high blood pressure and kidney disease. And that's how people would go on dialysis. So in order to help prevent some of those things, you just want to have like a good lifestyle, honestly, exercise, eating well, make sure you're drinking water, make sure a lot of people don't go to the doctors, especially men the ages 18 to 35. They don't go to the doctors. A lot of people in the African American community do not go to the doctors, and that's just shown to because of what was done to African Americans as a people with medical things. So they don't go to the doctors. So it's like you don't know what you don't know. Some people don't know until it's too late. So it's like honestly, like go to those yearly hospital checks, get that yearly blood work, so they could check on your cholesterol, check on your sugar, check on all your kidney functions, just so you can know how you could, do better with things that you could do to change exercise. Even if you don't want to exercise, you just sit at home and, while you're watching TV on the couch, just starts doing sit-ups 10 minutes a day. That's their exercise, and that still helps decreases the chances of having strokes.
Thanks, Jasmine. I know we want to, if they want to keep putting questions in the chat, we're going to go ahead and move on and allow Kathy to have some time, because I think some of the questions that you all have probably will be picked up with the next presenters. So Kathy Martin, she is a safety advisor and occupational therapist with the Business Network Division, and her professional interests include working with transition students and community reentry and retention with vocational accommodations, including work site evaluations, disability advocacy and inclusion, ergonomics, and assistive technology. So Kathy, please, well, thank you actually for coming to our first Friday, and you can begin when you're ready.
Thank you. It's going to take me just a second to get the screen situated and start sharing that. Give me just a second. Okay, can you see that? Screen okay, titled Returning to Work After a Stroke?
Not yet.
Yeah, it's still blank. Let's see. Okay, there we go.
How about now?
Yep.
Good now?
Yes.
Okay. Good afternoon and welcome. Thank you for joining me today. And I'm going to try not to duplicate any of the information Ms. Robinson just shared. It might be the first couple slides, there might be some duplication, but I promise after that, there won't be too much duplication after that. So as Wendy had said, my name is Kathy Martin, and I'm an occupational therapist with the Business Network Division. I use the pronouns she and her. I'm sorry, I'm just trying to adjust my screen here a minute. I have brown hair just past my shoulders, and I'm wearing glasses and a cream fuzzy sweater with black stripes. So the objectives for today's presentation are identifying what a stroke can look like and how it may affect an employee, identify strategies which increase success of vocational goals for individuals who have had a stroke, identify accommodations to maximize success when returning to work after a stroke, and discuss some real-life vocational rehab cases and recommended accommodations that were made. So a stroke is also known as a cerebral vascular accident, or CVA, which Ms. Robinson indicated, and it is a major cause of serious disabilities for adults. According to the Center for Disease Control, or the CDC, a stroke occurs when something blocks the blood supply to part of the brain or when blood vessels burst in the brain. In either case, parts of the brain become damaged or die, which can cause lasting brain damage. Many individuals who have had a stroke recover without limitations. Some individuals have temporary limitations, while others have more long-term issues. Strokes can occur at any age, but are more common in people 65 years or older. However, according to the CDC, 38% of people hospitalized for stroke were less than 65 years old, so still in that working range. So there are many common medical conditions that Ms. Robinson mentioned that can increase chances of having a stroke, such as the previous stroke or the transient ischemic attack or the TIA, high blood pressure, high cholesterol, heart disease, diabetes, obesity, or sickle cell disease. There are also behaviors or habits that can increase chances of having a stroke. And I know this was one of the questions for Ms. Robinson. As she said, a diet, lack of physical activity, alcohol, or use of tobacco. So how can I talk about a stroke without reviewing some very, very basic neuroanatomy and the functions of the various lobes of the brain? So the frontal lobe, which is the red portion of the brain in this picture, that controls personality, behavior, emotions, judgment, planning, problem solving, and concentration. The parietal lobe, which is the yellow portion in this picture, is vital for sensory perception and integration. It interprets input from other areas of the body, including language, sense of touch, pain, temperature, hearing, motor, memory, spatial and visual perception skills. The occipital lobe, which is the blue area, sits at the back of the brain and is responsible for vision. The temporal lobe, which is the purple area, is responsible for understanding language. It's also known as the Wernicke's area. Memory, hearing, sequencing, and organization. The cerebellum, which is the baseball-looking structure at the base of the brain, controls balance, coordination, movement, and motor skills. And then at the very bottom is the brainstem, and that is responsible for the vital functions of life. The automatic functions such as breathing, heart rate, body temperature, wake and sleep cycles, swallowing, and coughing. Now let's switch gears. Let's dive into the bulk of today's presentation. How having a stroke can lead to having a disability and the need for accommodations. First, how is disability identified? The ADA, or Americans with Disability Act, does not contain a specific list of medical conditions such as a stroke that constitutes a disability. Instead, the ADA uses 3 pillars when identifying a disability. They define a person with a disability as someone who, 1, has a physical or mental impairment that substantially limits one or more major life activities. 2, has a record of such impairment. Or 3, is regarded as having such an impairment. Therefore, depending on the residual deficits, someone who had a stroke may be considered as having a disability. So what is an accommodation? Title I of the ADA is a section of the Act that prohibits discrimination in employment. Title I requires that employers provide reasonable accommodations to qualified candidates and employees with disabilities. So if an individual has a disability that impacts work performance, they may need an accommodation. What is an accommodation? An accommodation is any change or adjustment to a job or work environment that permits a qualified applicant or an employee with a disability to participate in the job application process. Adjustments to the job application process ensures that a qualified applicant with a disability can be considered for a position. An accommodation is also adjusting the way a job is done, giving the individual the ability to perform essential functions of the job. This levels the playing field so an individual with a disability can perform the essential functions of that position. An accommodation is also an adjustment to the environment, so an individual can enjoy the benefits and privileges of employment equal to those enjoyed by employees without disabilities. Some examples of that include access to cafeterias, lounges, auditoriums, trainings, or even celebrations. So there are no set accommodations for an individual who has had a stroke. There's no specific list. Recommendations are based on how the injury affects the person and their ability to do the job. What are the functional limitations? Therefore, it is vital to ask various questions to identify what the limiting factors are. Questions often taken into consideration include, what limitations is the employee experiencing? How do these limitations affect the employee and the employee's job performance? What specific job tasks are problematic as a result of the limitations? What accommodations are available to reduce or eliminate these problems? Are all possible resources being used to determine possible accommodations? Once accommodations are in place, it would be useful to meet with the employee to evaluate the effectiveness of the accommodations and to determine whether additional accommodations are needed. Do supervisory personnel and employees need training? So residual effects of a stroke vary. As mentioned in our very basic neuroanatomy lesson, strokes may affect motor function, sensory function, speech, vision, balance, coordination, and/or cognitive abilities. I'm going to touch on 4 areas often most affected, which include vision, communication, cognitive skills, and motor function. With residual effects being different with each individual, accommodations must also be individualized. About 2/3 of people who suffer from a stroke have vision problems, including visual field loss or loss of vision on one side, nystagmus, which is the rapid eye movement, strabismus, which is the eye turning, ocular motor dysfunction or eye tracking control issues, or diplopia, which is the double vision. For those with vision loss, technologies are available to help overcome some of these limitations. These technologies may help with reading printed material, accessing computer information, writing notes, completing forms, assembling parts, driving, working with light sensitivity, distinguishing colors, and being mobile. To accommodate for vision impairments, one may have to train to move their eyes and head towards the weaker side. The more you scan and move your eyes and head to one side, the quicker you will detect objects on that side and reduce your risk of missing objects on that side. Changing the font color on one's computer, making sure lighting is good, have it positioned to your side, not behind you, as this causes shadows. Using a highlighter feature for electronic text. Use of an eye patch or closing one eye to reduce the double vision. When reading, use rulers or markers to highlight the beginning and end of sentences and to help keep your position along the line of text. Implement the use of an electronic reading program. One might have to use an OCR or an optical character reader. Scan a document into an electronic device so the device can read the document. Vision problems are not always obvious for other people to see. You might find it helpful to explain your sight problems to colleagues or friends to help them understand the support that is needed. Seeking services from a specialist can also help identify deficits and help to identify strategies that are needed and how to implement the strategies into everyday life activities. Repetition will be needed for the strategies to become second nature or feel natural. So hemiparesis, which is the weakness on one side of the body, is one of many residual effects of having a stroke that limit physical or motor functioning. An individual experiencing hemiparesis may have difficulty walking, standing, balancing, climbing, grasping, or gripping objects for precision or detailed work tasks, and could experience general muscle fatigue or lack of coordination. Depending on the area of the brain where the stroke occurred, either the right or the left side of the body may be affected. The degree to which motor functioning is limited depends on the individual. In some cases, one may even experience hemiplegia, which is one-sided paralysis. Even though improvement in physical ability can be seen as a result of therapy and various forms of treatment, hemiparesis also limit an individual's ability to perform a job or even parts of a job. Those planning or preparing to return to work following a stroke may need to explore accommodation options. Depending on the type of job and the essential functions of the position, one or more accommodations may be needed to ensure that a return to work is successful for an individual with hemiparesis. They might need larger handles or levers to operate controls. They may need to use carts for carrying objects, or even use scooters or motorized carts to access the entire floor. They may need walkers with seats or stair climbers, grip aids, perch stools, or even enlarged handles. Strokes can also impact communication in a variety of ways depending on the part of the brain that was affected. Over 33% of stroke patients have some form of speech problem immediately after a stroke. Typical speech and language impairments arising from stroke can be classified into two basic categories: aphasia and motor speech disorders. Aphasia, which causes difficulty understanding and using language, most often caused by strokes on the left side of the brain, is further broken down into two types: expressive, which is the ability to get the words out, or receptive, which is understanding what is being said. Aphasia may also affect the ability to read or write or deal with numbers. The motor speech disorders include dysarthria, which involves a weakness or impaired control of the muscles involved in the production of speech and voice, and apraxia, which impacts one's control over the movements of the muscles used in speaking. They may struggle to say words correctly because they can't get their tongue or lips to work quite right. Many of these individuals have a hard time pronouncing speech sounds properly because of the weakness or lack of control in the muscles. Some individuals who are recovering from speech impairments may benefit from using assistive technologies such as an augmentative and alternative communication device, also known as an AAC. They may also have learned or be in the process of learning compensatory strategies, such as using a slower rate of speech or using other communication methods like typing, writing down information, drawing, or gesturing to support the enhanced communication. Other accommodations could include job restructuring, and this is a form of a reasonable accommodation. For example, if answering the phone is a marginal job function, switching with another marginal job function could be considered as an accommodation. One might need to eliminate distractions or keep directions simple. So they may be able to reply with yes, no. Remember, just because an individual has trouble with speech, it does not mean they are hard of hearing. Speak in a normal voice at a normal volume. In the case of a stroke where one or more cognitive domains may be affected, including attention, concentration, perception, memory, comprehension, reasoning, problem solving, judgment, initiation, planning, self-monitoring, and awareness. Again, there are no set accommodations for an individual who has a stroke. Recommendations are based on how the injury affects the person and their ability to do their job. Therefore, if someone is struggling from cognitive deficits, the skills should be looked at and addressed, not all of the cognitive domains. For example, accommodations for someone struggling with concentration could include reducing the distractions or the clutter, use of a white noise machine, modifying stimulating environments, raising the panels or walls if they are in an open cubicle style setting, relocate the individual to a lower traffic environment, and use of headphones to reduce the sound. So for someone who might have some difficulties with problem solving, use of visual aids or checklists, flowcharts, introduce problem solving components into the supervisory process. For someone who might have some difficulty with memory, use of journaling or writing notes, or recording meetings, implementing the use of a calendar, and establishing a daily routine or structure, and provide information in small pieces rather than in large chunks. Someone that has difficulties with initiation, we could use task reminders via digital devices, use of calendars or hourly check-ins. So let's go over a few case studies. This first individual who had a stroke is a full-time computer programmer, and she's working from home. The barriers that she presents with include decreased balance and mobility, fatigue, impaired strength and coordination, and she has accessibility barriers within the home. So accommodations that were recommended include scheduling structured days, being proactive and schedule those rest breaks, use of a dictation software program that would reduce the amount of typing that would be needed, ergonomic equipment such as a trackball or modified keyboard, or use of keyboard shortcuts, an adjustable height desk to accommodate for the wheelchair that she was using. Again, because she worked from home, it was critical that she had entrance into and out of that door. So it's really important that the ADA guidelines are followed, and consulting with a contractor is also very important. Again, because she works from home, it's also important that she have access to her bathroom. So the bathroom modifications included use of a grab bar and a handheld shower. And we had to recommend widening the bathroom door, which gave her the ability to even access her bathroom when using her wheelchair. Durable medical equipment that was needed was use of a shower chair and a high-rise commode. So the second case study is for an individual, again, that had a stroke. She was returning to work as a familiar position as a medical case manager. The deficits that she had involved vision. So her barriers included double vision, impaired eye movements, difficulty tracking, and limited ability to sustain focus on fixed objects. So some of the accommodations that were recommended for this individual included dual screens, a larger monitor, modification of the screen contrast, screen reading software, a dictation software program, an alternative keyboard, and lighting. It was important that she have the fluorescent lighting removed and it was replaced with a task lamp. The third case study is for an individual who was a college student who suffered a stroke. The barriers that this individual had included executive functions, planning, working memory, and executing, organization and time management, reading comprehension, and coordination impairments. Some of the recommendations for this individual included use of assistive technology, again, that dictation software program, use of a smart pen that gave him the ability to record his lectures, and those lectures were then transferred into a written format, and he was able to download this into his computer. He used a graphic organizer software program. He also used low-tech devices, which include just use of a simple wall calendar. He implemented the use of a color coding system that helped him stay organized. And there were various different scheduling strategies that were implemented. He also used the university resources, which included extra time for tests, use of a quiet room, and he used a scribe or note taker when in class. So in conclusion, no stroke is the same. Every person may be affected differently. A stroke can happen at any age, and treatment and recovery is individualized. And that is one of the most important factors of this presentation. You can't just take a general list of accommodations. They really have to be individualized based on their functional abilities. Interactive process is key. So some resources to share, and feel free to email me because I was just informed that these won't be going out to you. If you want any of these, email me and I can send them to you. But Michigan Rehab Services Job Accommodation Network is a federal program, and they are a very resourceful program. You can click on the functions that are limited, and they will pull up a whole list of accommodations that potentially can benefit the individual. The National Institutes of Health, and the Center for Disease Control. So here is my email address, my contact information, including my phone number, if you do have any future questions. I'm going to turn it back over to Wendy, and we probably are limited for questions, but I'll let Wendy share if we have time available.
Oh, that was great, Kathy. I appreciate your information. It was very informative. I'm still learning some things. I guess for the sake of time, we can allow Amanda to speak, and then if everyone has questions, you can just you put them in the chat, and then we can finish off with questions, and then everybody can kind of tap in based off their question, if that's okay. Okay, so Amanda is a clinical dietitian who helps patients in the hospital with acute nutrition needs. In addition, she is the owner of Amanda Bombay Nutrition Counseling, where she helps clients address their nutrition concerns from a non-diet approach. Amanda is also a certified personal trainer and yoga instructor, and she attended Rutgers State University and the College of William and Mary. So thank you so much, Amanda, for accepting the invite from this total stranger. I appreciate you really very much. So Amanda, go ahead and you can take it from here.
Okay, sure. All right. Can you all see my screen?
Yes.
Okay, great. So yeah, I'm glad to be here with you all. And this is February's Heart Month. So I thought I would do sort of like a heart healthy nutrition theme here, going with the pinks and stuff. Yeah. So if you didn't know, February is heart health. And like we learned earlier, that strokes are a cardiovascular event. So start affecting your cerebral and vascular system. So a heart healthy diet approach is going to be one that you would want to do in terms of preventing a stroke and then afterwards as well. Okay, so my approach is all, like I said, very anti-diet. So I don't endorse any specific diets, plans. Everything that you need can be very realistically obtained. You don't need to do anything crazy. So that goes into just a little background there. Just some things I hope that you get out of this. I hope that you can maybe describe a heart healthy diet and name some ways that you can incorporate more fruits, vegetables, and grains into your eating routine. Okay, wait. Okay, so you may have heard about the Mediterranean diet, and it is research. There's a lot of research that has gone into it. It's research to be one of the most effective. Diet is really just a way, diet just means eating style. So we want to think of it that way, not like a diet of where there's rules and restriction. It's just a way of eating, a lifestyle. So a Mediterranean way of eating is summarized in this pyramid. And there's a lot of information on here, but the first thing that you might see is the biggest section. So the biggest section of this pyramid is this area of fruits, vegetables, and grains. So that area is what is emphasized to be where you want to get the most of your nutrition from, where you're going to get a lot of energy and protein. And because you can see how the plant-based area, so not animal foods, plant-based foods, it's the biggest part of the pyramid. So that there is a lot of research as well about plant-based diets being very heart healthy and for prevention of heart attacks and strokes, and then also for recovery of those events. So again, trying to make this as simple as possible. The biggest area is going to be fruits, vegetables, grains. When we say grains, we mean whole grains. That's going to be like whole wheat bread, things with a lot of fiber. So again, like whole wheat pastas, beans, legumes, lentils, seeds, nuts. These are all going to be part of that plant-based section of the pyramid. And then as you go up, you'll see that fish and seafood are the next part. And the reason for that is that fish, seafood have omega-3 fatty acids, and those are heart healthy fats. So there's a lot of research that shows those omega-3 fatty acids can be protective for our heart. Some people may say, oh, can I just take a pill for that? You can, but you're not going to get the same out of it, all the same benefits as if you were to incorporate more fish and seafood into your diet. And the recommendation is to incorporate 2 servings of fish or seafood into your diet per week. So 2 servings per week. It can be any fish, any seafood that you see there. So like I said, that's the reason why. Oh, another reason why you can't just take this from a pill is because there are other things in the fish and seafood. So for example, fish and seafood also provide you with vitamin D and selenium and other vitamins and minerals. So you really get the most effect, most bang for your buck when you eat the food, as opposed to taking a pill. And then as you go up the pyramid, you'll see the next section, it gets smaller. So poultry, eggs, cheese, and yogurt. These are things that can be incorporated into the Mediterranean diet, but they're not going to be as big portion size as your fruits and vegetables, or as frequently as your fruits and vegetables and grains that are in the base of that pyramid. So it means you can have cheese, eggs, chicken, yogurt, but not as frequently. So there's ways you can incorporate that. And then meats and sweets are at the top of the pyramid, showing that they're the smaller portion size and you just have them less frequently. It doesn't mean you need to go on a strict vegetarian or vegan diet. All foods can be incorporated into a healthy eating pattern, but in a Mediterranean diet, like I said, which has been researched to be very effective at both preventing and helping people after stroke and heart attack. And I say helpful to prevent, it doesn't mean that you'll never have a heart attack, because there are other factors. It doesn't mean you won't have a stroke. Like I said, there are other factors that we learned about, but this is one part of it. And then I should have maybe said this at the beginning, the very base of the pyramid is the physical activity. So we already learned about physical activity being really important for our heart health. Just walking, dancing, you could dance in your home. You don't have to join a fancy gym or anything like that. The most basic stuff really works. Eating with others is also really important. There's a lot of research about loneliness as being a negative effect to our heart health. And so eating with other people, going for walks with other people, being around just anyone as much as you can is a part of that Mediterranean diet. And then on the side, you do see there is the wine in moderation. That's part of the Mediterranean diet. I should say that if anyone has had a stroke or on any medications like blood thinners, you would probably are not going to be able to drink wine. You have to check with your doctor on that. But wine in moderation is a part of the Mediterranean diet. But the moderation is 1 drink per day for women and 2 drinks per day for men. And you can't save them up. That's always a question people ask me. So it's just 1 per day for women. Can't save them all up for Friday. Doesn't work like that. And then water is on the side of the pyramid as well. We want to drink a lot of water. That we want that to be our main beverage, and we want to avoid the other drinks, especially ones with sugar like soda, coffee and tea with added sugar. Juice is another one that has a lot of sugar, and it just can raise your blood sugar very quickly, especially for diabetics. Juice is not recommended. So I'm going to go to another version of this. This is called the Heart Healthy Plate. And another way to look at it, think about the Mediterranean diet, is how does this look on my plate? So when I make a plate for lunch or dinner, I really want to make half my plate non-starchy vegetables, any fruits and vegetables, anything you want. These can be a salad, it can be raw fruits or vegetables like a salad, or carrots or pepper sticks if you like that. It can be cooked vegetables that are roasted, microwave steamed, however you like them. They could even be, you could even put your veggies into a soup, like if you made a veggie soup, a chili with a lot of beans would be another way to add more veggies, a broccoli soup, a tomato soup, garden veggie soup, lots of ideas, just throwing some out there. And then with our fruit as well, you can eat fruit pretty much any way you want. So we want to make half our plate fruits and vegetables, just the simplest way to describe this. And then the other half of our plate will divide between the protein and the whole grains. So we talked about a little bit about protein. We really want to get protein that are lean, and lean meaning low in saturated fat. So we want to avoid the processed meat, bacon, sausage, ham, salami. Those types of processed meats are made with salt. And so the salt, unfortunately, can raise our blood pressure, and that can have negative effects for your heart. And then the whole grains, we talked about other legumes. And I know we're running out of time, so I'm sorry to have to kind of go through this quickly. There's some other information here about how to incorporate healthy snacks. Cup of non-fat yogurt with some blueberries and nuts could be a great healthy snack, or some hummus with veggies. You can have pita bread, things like that. Other general tips, we talked about exercise already. Really, fiber is really important in a heart healthy diet. People who go on other diets, low carb, whatever, Atkins, what happens is people end up cutting out fiber from their diet, but fiber has a protective effect. Fiber can actually lower your cholesterol, and it's really good for your digestive tract. So it has a protective effect for your heart. So eating more fiber rich foods, that's the fruits, vegetables, whole grains, legumes, that would be like lentils, nuts, seeds. We talked about eating fish twice a week. Try to have some meatless meals. So for example, you could make a chili with beans instead of meat. You could use tofu instead of chicken in like a stir fry. You could use beans as a main dish instead of meat. And then we talked about trying to avoid empty calories. All foods can be part of a healthy diet. Doesn't mean you can't ever enjoy a piece of cake or a yummy donut, but we just want to limit those and try to emphasize the fiber rich foods. And then, like we talked about the alcohol, first and most importantly, you have to make sure it doesn't interfere with any medications. The next caveat would be that we want to limit alcohol, because excessive alcohol intake is definitely related to an increased risk of cardiovascular events. And then sodium as well. So like I said, I know we're running out of time, so I'm going to just go to our next slide. But these are some general nutrition tips. We want to have adequate energy throughout the day. So that means eating 3 meals, breakfast, lunch, and dinner, and having some snacks in between. Skipping breakfast, there's a lot of research that shows people who skip breakfast just end up overeating later in the day. All foods, like I said, can be part of a heart healthy diet. This means our cultural foods, any foods that you grew up with, they can all be incorporated into a heart healthy diet. You don't have to give everything up. And even fun foods, like I said, birthday cake or a donut or something, those fun foods can be incorporated into a heart healthy diet. You just want to make sure you're getting more of those good fiber foods. Okay. And then one other takeaway is that restriction leads to overeating. So if I say I'm not going to eat bread, that's all I'm going to think about is eating bread. So again, if we don't want to overly restrict, because that's going to lead to overeating. So just incorporate more good food, meaning the fiber, the high fiber foods, fruits and vegetables. And buy what is in season. You can use frozen or canned fruits and vegetables during the winter. Really eating seasonally is going to be more cost effective. So that's an important tip. And then I think this is my second to last slide. This is just an example of some plant-based proteins. I think we already talked about it, and I know it's 2:00, so I will just skip this. And this so a quote here: nourishing your body is the best form of self-care. That's from an Intuitive Eating book by Evelyn Tribole and Elise Risch. If you're interested in learning more about that, I would encourage you to check that out. And I just want to say thank you for your time. My name is Amanda Bombay. Like I said, I'm a dietitian. I have a private practice. You can learn more about that. My website is amandabombay.com. That's it. I know it's 2:00, so I will, yeah.
Oh, no, you didn't have to rush that fast, but thank you. So, that was great, Amanda. All of your information was really good. So does anybody have, I see one question so far in the chat, so I guess I can just jump on here. Someone wants to know, can we eat fried fish, or is it better to prepare a different way?
Yeah, so unfortunately, it just depends on how it's fried, but yeah, a general rule of thumb is to avoid fried foods as much as possible. You could saute or bake. Some people love doing an air fryer. That's like, some people love their air fryers, and it uses just like a little bit of oil. You can use olive oil or canola oil when you're cooking, but as a general, you want to avoid fried foods.
So the air fryer can be a good option if you
Yeah.
just want to have that fried. It just kind of takes some of that other stuff off of there. Okay. Anyone else have any questions for Amanda, Katie, or Jasmine? I'm sorry, Kathy. And if you would like any of their contact information, just I can send that out to anyone. You could just contact me directly and I will share their information. Oh, I'm sorry, another question popped up in here. Oh, great presentation. Thanks, Nico. Yes, so you got a great presentation response. Okay. Okay. Well, I don't see any more questions. So I do appreciate you all for taking the time to come out, and happy Friday to everyone else. All right. Thank you. Have a good weekend, everyone.
Thanks,
You as
everyone.
well. Thank you.
Bye-bye.
you,
Have a
Wendy.
good day.
Bye.